Hi, everybody. My name is Kaylee Dayton. I'm an ICU nurse practitioner, and I started my career as a brand new nurse in an awake and walking ICU. And this was very normal in that ICU to have almost every patient awake and walking. They'd allow patients to wake up right after intubation and get them up even hours after intubation. Some exceptions might include refractory epilepticus, open abdomen, the severity of alcohol withdrawal, any problem with oxygen consumption like severe ARDS or uh, cardiogenic shock, things like that. But otherwise, patients were indeed awake and walking, even on high ventilator settings. And so I thought that was completely normal. And then I became a travel nurse and I went to other ICUs and I was hit with this culture shock when immersed in this culture of deep sedation and immobility for every patient on a ventilator. And I returned to that unit as a nurse practitioner and I immersed myself in the research and came to really appreciate the drastic difference in outcomes and as well as workload when we truly practice the ABCDF bundle and master early mobility. So that's what I want to address today is early mobility. But before we get there, I think it's really important to really understand why and how to avoid some of our standard practices like deep sedation for every patient on a ventilator. And I think the problem is often rooted in our cultural beliefs and some of the misunderstanding that we have about sedation. So let's address one of the things that we commonly say is that patients are sleeping under sedation. Studies show that sedation is not sleep. When we look at brain activity under EEG during sedation, we see that sedation actually disrupts the brain so severely that they cannot get REM cycle. So patients are not sleeping, and sleep deprivation from sedation is one of the main mechanisms by which sedation causes delirium. So when patients, we've all gone through periods of sleeplessness and we've all felt the effects of it, but have any of us gone days to weeks without sleep? It injures the brain and it causes an acute brain failure, which is what we call ICU delirium. And so when patients are not sleeping and they develop ICU delirium, most commonly they are having terrible hallucinations, vivid nightmares, which cannot call them any of that. Really, when you talk to a survivor, you'll come to realize that they were experiences. They were vivid realities to them. They really thought their kids were kidnapped. They really thought that they were in enemy territory having genital mutilation. They think the worst things. They hear and feel things from the ICU, but it gets twisted into something far worse than the ICU could ever do to them. And that is often what causes post-ICU PTSD, which is a lifelong chronic condition, and it severely impacts quality of life as they have panic attacks, they have flashbacks into those scenarios that they lived in delirium, and they're still not sure years later what was real and what wasn't. That acute brain failure also leads to chronic brain failure. That injury that the brain incurs under sedation can create a post-ICU dementia. So patients that have developed delirium are at 120 times greater risk of having cognitive impairments after the ICU. So we really need to be panicked and aware of the damage that we're causing when we're giving sedation so that we use that to do a risk versus benefit analysis. Each time we go to sedate a patient, instead of intubating and automatically sedating, we need to stop and say, does this patient have an indicator for sedation, and what is it? How long will it last? What can we do to minimize this harm? Delirium sets them up for mortality. It's an independent risk factor. That's why when we give medications like midazolam that have a higher rate of delirium, it comes with a higher rate of mortality. Patients with delirium are twice as likely to die in the hospital and 3 times as likely to die afterwards. For every 1 day of delirium, there's a 10% increased risk of death. So we have to recognize that not only is this a very lethal practice of deeply sedating every patient on the ventilator, but it's also very laborious for our teams. It increases length of stay, increases time on the ventilator, the violence, time, tube removal. We have to recognize that delirium can double the care requirements and the nursing hours required for care. So when we say that we don't have the resources or time to implement evidence-based practices such as delirium prevention and early mobility, we're really confused about what is actually costing us the time. So in addition to the risk of mortality and the acute brain failure, we have to also recognize what happens to the muscular system during sedation. The muscles are under attack for a lot of reasons during critical illness, but some of the top culprits are prolonged bed rest, and under sedation, it's actually worse, it's immobility, and then the drug effects of the sedation that we're giving. So to understand how dangerous that is, we need to appreciate the role that the muscles play in survival. When muscles break down, during muscular atrophy, it ignites this huge inflammatory response that can lead to multi-organ failure and affects many different organ systems, and worsens critical illness, increases the chances of dying. So during the first 10 days of an ICU stay, we can lose up to 30 to 40% muscle mass. And not only do we lose muscle mass, but we can lose a neuromuscular connection to our muscles because of the sedation that we're giving. Sedation is one of the top reasons for that muscular atrophy. It has the most impact to muscular atrophy. So when we look at different causes of muscular atrophy that are notable, sedation is the top. Within less than 7 days, there is a very notable muscle loss because of sedation. And we have to understand that sedation is not good for the muscles. Propofol disrupts the sodium channels of the skeletal muscle, which disrupts the neuromuscular connection. It increases insulin resistance. It's likely myotoxic. It can cause diaphragm dysfunction. So when we're giving propofol, we need to understand the actual risks that come with it. And as we immobilize our patients, we're again causing greater inflammatory response, multi-organ failure, and increasing the risk of dying and having lots of different complications, such as DVTs, pressure injuries, ventilator-associated pneumonia, death, delirium. Immobility can be independently a risk for delirium, which is going to increase our workload. And it creates ICU-acquired weakness, which makes patients at 8 times greater risk of dying. This leads to failed extubation, which we've all seen during COVID when patients become too weak to cough, clear their secretions, take their own breaths. They end up having much more time on the ventilator, failed extubations, tracheostomies. They then require discharge to LTAC, which takes up a lot of time as LTACs are full, can't take care of patients, but they can't get off the ventilator. They're stuck in our ICUs, they're bottlenecked. That's more time, resources, and workload for our ICU teams, and puts our patients at huge risk of dying. Patients that have ICU-acquired weakness as well as diaphragm dysfunction have a 2-year survival rate of 36%. So before we allow our patients to just atrophy only for being on a ventilator, we need to take this into account. The best way to prevent that atrophy is early mobility, avoiding sedation, prompt nutrition, and glucose control. So we can make early mobility really complicated, or we can just be logical and quick about it. In the Wake and Walking ICU, patients are awake right after intubation and often mobilized shortly after, and even walking. We want to preserve whatever baseline they had. So they walked into the ICU or walked into the hospital, even short of breath, hypoxic, hypotensive, whatever the reason was. Once they're stabilized, they should be able to walk even better than they did a few hours before. So why not? So we can start with sitting. Even sitting engages the diaphragm, the respiratory muscles. It helps the lungs, improves lung aeration, all these things. So there's really no threshold unless they can't oxygenate with movement or they're hemodynamically unstable. And so we can set them up, assess, watch the monitor, ask them how they're feeling, and they can tell us and we can see if they are doing well and are stable. What's the harm? And then progressing to standing. If they are unstable, we can just lay them back down and try again in a few hours. There's not, early mobility is very safe. Within thousands and thousands of events that have been studied, there's a less than 1% harm rate. So then we can progress from sitting to standing, which is going to engage obviously our lower extremities, but our diaphragm, our respiratory muscles even more. This has 2 patients, sometimes in the Wake and Walking ICU with our COVID patients. Because the short staffing, it's the nurse holding the tubing while the patient gets themselves from the bed to the chair. When we preserve their muscle, we make the workload easier. When we think of early mobility, I think we imagine thrashing, anxious patients that are trying to pull their tube out and they're super flaccid or difficult to even sit up. It's taking in 6 people and ceiling lift. That's just not the reality when we are prompt and progressive about it. When we prevent delirium and we prevent muscular atrophy, we prevent a lot of work and risk. And if they're doing well with sitting or standing, then we can progress to walking. This is a patient with Down syndrome, mycoplasma pneumonia and ARDS. He has a PEEP of 12 and 80%, I think, in this video. And yet he walked very, very well. And then we can make it fun. And mobility is everyone's job. It's not just physical therapist's job. So if the nurse helps them get to the chair in the morning, which is not that hard and they're strong enough, they can have them do leg raises and arm raises and resistant bands while they're getting their medications ready. It can be this really simple and naturally integrated part of our process. In the COVID unit, they obviously couldn't walk around the unit like that we usually do. And so they could do arm bikes, leg bikes that have that continuous cardiopulmonary exercise. We can get creative. We can make it fun. This is a team in Brazil doing squats. Again, there are 2 people and they're just standing there doing squats. So if the ventilator can't mobilize into the hallway or around the room, we can do squats, stepping or taking steps at the bed. Anything is more beneficial than sedation and mobility. We can also be creative. So this team in Brazil also does volleyball with their patients. And it's just fulfilling to actually get to know your patients, understand who they are, watch them progress, watch them get off the ventilator successfully and quicker, and then walk out the doors. It's just so much more worth it. ICU is a lot of work. Sedation and mobility is a lot of work. So we can work harder or we can work smarter and have more fulfillment in our careers through early mobility and just have moments of human connection and humanity. This is a COVID patient on a PEEP of 10 and 50%. You can tell he has not been sedated throughout his time because he's cognitively and physically intact and likely to get extubated the next day or 2. The A-to-F bundle has incredible outcomes. It decreases death by 68%, decreases delirium by 25 to 50%, decreases mechanical ventilation. ICU readmission goes down by 46%. We cannot afford to have patients coming back to our ICUs repeatedly. We don't have the staff and the bed space for that. So the A-to-F bundle is the answer. It increases discharges home by 36%, and the outcomes are dose dependent. So the more we mobilize patients, and the more we avoid sedation, the more success, the better outcomes, the less work we will have for our teams. And we can become masters at early mobility. This is the team in Brazil walking a patient on CRT and mechanical ventilation. So when we immerse ourselves in the research and strive to practice evidence-based medicine, we will find that early mobility is a life-saving intervention and key for our care of patients in the ICU. Thank you.